everyone. I'm Dr. Linda Bradley, founder and chairwoman of Cleveland Clinic Celebrate Sisterhood. Welcome to this year's edition of Celebrate Sisterhood 4.0. This is a community outreach and education program that empowers multicultural women to embrace self-care and to strive for optimal health for themselves, their families, and their communities. This event is pre-recorded. If you have any questions about the information shared with you today, please email celebratesisterhood@ccf.org. We have a great group of experts here with us today. Joining us a little later for discussion about emergency contraception will be Dr. Ashley Brandt, staff physician in the OBGYN and Women's Health Institute, and she is the director of complex family planning and co-director of the Pregnancy Early Assessment Clinic at Cleveland Clinic. But joining us now for the discussion is Dr. Miriam Kramer, professor of OBGYN and reproductive biology, and she's director of global health research at the Cleveland Clinic Lerner College of Medicine. Dr. Joy Robinson Tidmore is staff physician in the OBGYN and Women's Health Institute at Cleveland Clinic. And Dr. Sarah Vidge is assistant professor of surgery and center director of male fertility in the Glickman Urologic and Kidney Institute in the Department of Urology at Cleveland Clinic. Today, we will take you through our contraception boot camp. Our goal is to make you more knowledgeable about contraceptive options in 2022. Our panelists will discuss many options, including methods available for women and for men. However, please contact your own healthcare provider to discuss specific personal questions that you might have after listening today. Choosing between types of birth control is personal. There is a method for nearly everybody and everyone's lifestyle. In fact, there are over 16 total methods, and more are counting. More than ever, crucial conversations about birth control are needed. More than 2 centuries ago, the average woman had 8 to 10 pregnancies and deliveries in her lifetime. Today in the U.S., the average woman has 1.93 children. Most women spend approximately 10 years of their reproductive lifespan planning for pregnancy. The remaining years, when pregnancy is no longer desired, contraception is needed for sexually active individuals with a uterus until menopause, which is defined as 1 year without a menstrual period. So why is a conversation about contraception critical? Because it's important to be as healthy as you can before achieving pregnancy. Self-care is critical. Smoking cessation, controlling hypertension, diabetes, and achieving ideal body weight improves pregnancy outcomes for mothers and babies. 49% of pregnancies that occur in the U.S. are unintended. Out of those unintended pregnancies, 52% were due to lack of birth control use. 48% occurred due to the failure of a method used. None of the types of birth control on the market are 100% effective with every use, though some are 99% effective. Today, during our session, we will discuss the 5 categories of birth control currently available. What are they? Number 1, those that prevent ovulation, such as the pill, vaginal ring, long-term implants, contraceptive skin patches. Number 2, types of contraception that prevent fertilization, such as intrauterine device. And these include the copper intrauterine device and progesterone hormonal devices. Thirdly, we'll talk about barrier methods. Male condoms, female condoms, contraceptive sponges, cervical caps, spermicides, and diaphragms. Natural methods, such as cervical mucus examination or basal body temperature, also called BBT. Finally, we'll look at surgical methods for women, including tubal ligation, and for men, vasectomy. So let's get started. First, we're going to speak with Drs. Kramer, Tidmore, and Vidge. So let's look at contraceptive needs. What are the ages that women need to understand in terms of when pregnancy can occur? And I'm going to first start with Dr. Tidmore. When you think about contraception, I've got two questions for you. How early should we think about it? And then I'm going to transition to one of our oldest methods, being the birth control pill as we know it. So what do we know? When can pregnancy occur? How early? How late? Sort of what are the extremes?
So clinically, when you think about a woman coming in concerned about birth control for contraception, you have to think about their own ovulatory cycles. So once a young woman, establish ovulatory cycles, they can become pregnant, and they can become pregnant until menopause, which is clinically defined, as you said, as a year consecutive amenorrhea or no periods. So that's the time frame where pregnancy prevention, if that is your choice, if that's what you're intending, is important for you at that point. As you mentioned, birth control pills have been around since the 60s and have been tried and true. We've also made a lot of advances with oral contraceptives to make them safer and actually achieve other things that have been advantageous for women who are taking the birth control pill. But for the most part, oral contraceptives have included both estrogen and progesterone, and they work to help prevent pregnancy and have been effective.
I'm going to switch and pivot for just a moment to Dr. Vidge. So I've asked Joy about the ages for pregnancy. We've heard as early as ovulation occurs, which in some girls, as we know, is age 9, and the oldest might be mid to late 50s. How about men? Let's ask questions and get some answers about men. What's the earliest that a man can impregnate a woman with a uterus, or a person with a uterus, and what's the oldest?
Sure, it's a great question, and it's a very different answer on the male side. So when we talk about the sort of younger end of the spectrum, when boys start going through puberty, at some point during that process, which we know can take over the course of a few years, the production of sperm essentially turns on. Exactly when that occurs, there is not a great sort of external marker, and it's variable from boy to boy, but it's essentially during the puberty process. And then men continue to make sperm until the day they die. So that's a very big difference between men and women. So you can cause a pregnancy in your 90s as a male.
Interesting. I won't ask you if you've heard that occur, but I've heard of it. And Dr. Kramer, let me ask you, Joy has started with a little description, which is great for oral contraceptive pills. So we think of oral contraceptive pills. Tell me what's in it. What types of contraception? We think of oral, but the hormones that are in it? If women have trouble swallowing a pill, what are some of the other methods that we think of when we think of the broad category of hormonal contraception?
That's a great question, and thanks for having us. So oral contraception typically is estrogen and progesterone, although there are pills that only contain progesterone. But if you have trouble swallowing a pill, or if you don't remember to take a pill every day, there's so many great options now for hormonal contraception. There are pills, patch, ring, vaginal ring that you can insert, a patch that goes on your skin, an injection that you can have. And so there are many different delivery systems. And the IUD, there's an IUD that does have a little bit of hormones, and there is a implantable rod that also has hormones. And both of those are just progesterone only.
And Dr. Tidmore, let me ask you again about the oral contraceptive pills or hormonal contraception. Do patients need to see a doctor to be given a prescription? What's the current status? Virtual visits, telephone visits? Do they need to come in? What do we know at this time?
Well, ideally, as a clinician, I would like that people and women who are receiving medications and birth control pills be seen by a doctor just for some type of physical exam to make sure they're healthy and other regards. However, if the issue is just to achieve a method of contraception, virtual visits have provided that information in a timely and very thorough way. And we've been able to achieve the same goal in getting medications and these birth control items and contraceptive items to women without mandatory visits to the doctor, as it has been in the past.
Dr. Kramer, do you have anything to add to that?
I would just say, we've held women hostage a little bit to coming in to get their blood pressures taken or to have a pap smear. And I think, it's really important to prevent unplanned pregnancies. So if they can get in a little later, I agree. I think people should see their providers. I'm not minimizing, the importance of a provider. However, I want to empower women to be able to get contraception when they need it.
Now, many women use birth control pills, yes, to prevent pregnancy, but there are women or individuals with a uterus that may not need contraception per se. But what are some of the unspoken benefits of birth control pills? I'll ask Joy, Dr. Tidmore.
Birth control pills or contraceptives also have other benefits other than providing contraception. A lot of young girls, as they start the periods, do have irregular cycles. And the birth control pill is one way to regulate the cycle, diminishes the blood loss during their periods, and also helps prevent or diminish cramps or pain that comes with the periods. Often during this time of adolescence, young girls also have issues with their skin and acne. And this has also provided a way to help prevent or diminish those concerns as well for girls. So
Excellent.
Those are their side effects.
Perfect. And for Dr. Kramer, let me just ask you, what are some of the myths about birth control pills? Do women gain weight? Do they lose their hair? What about sexuality? Things like that. So we've heard the benefits: skin, regular periods, less menstrual cramps, less likely to become anemic, regulation of the menstrual cycle. Those are all great benefits.
Less cancers, less risk
that's
for
right.
cancers.
That's right. Yeah, uterine cancer and ovarian cancer. Correct. Absolutely. Prevention. But tell us more.
So, I think that I don't want to diminish people's side effects because it's very important to have your patients not have fears of what they're going to use, or if they've had terrible side effects. I think any pill can cause any side effect. However, big studies have shown that pills don't generally cause weight gain. Myths about oral contraception, that mood changes, and I've seen sometimes people have mood changes, but generally people do okay if they're monitored. And luckily, they can be a method that you stop right away. And so those side effects will go away as well. So weight gain is the biggest. Weight gain, mood changes, headaches. Am I missing anything big?
I think we've covered it. That's perfect. And I do want to ask Dr. Vidge, I was asked probably a decade ago by a men's magazine, nonetheless, to talk about contraception. And I'm like, well, what does a man want to know in terms of female contraception? I'm going to spin it a little bit here. Do you have guys coming in asking you about female contraception, birth control pills, since we're on that topic, what they've noticed or what they have concerned about, or do guys ask?
I think just anecdotally, based on my experience seeing patients, is men who are coming to me for a vasectomy, which I know we will probably get into later in the session today. Many of them are coming in to allow their partner to get off of some form of birth control. And so sort of to take the burden off of their partner. So I think that tends to be what I see day to day when I'm having discussions about contraception with my patients.
Okay, so coming off of it for whatever reason, and we'll look at some of those in a moment. Just to make sure that we've closed the story about hormonal contraception, if a woman starts today on the birth control pill, ring, patch, when does it become effective? How soon after starting a pill, a patch, a ring can we tell her that she could avoid use of condoms or have sexual activity with decreased risk or the lowest risk for pregnancy? Miriam, I'll ask you that.
That's a great question. So it depends when you're starting it. So a lot of times we have women start at days 1 to 3 of their cycle, which is just after the period. However, that's not convenient for a lot of people to come in right after you get your period. Maybe you can't get an appointment. Maybe you don't have childcare. So if you're already on a form of birth control and just switching to another, it's effective immediately. Generally, we have people use a backup method for 7 days if they're not starting within days 1 to 3.
And I'm going to ask Dr. Vidge this question because we're going to speak today about other types of contraception in a moment, intrauterine devices. But one of the oldest methods for men has been condoms, right? Tell us what you want our audience to know about condom use. Types of condoms, how they're used, how effective, those kind of things. Tips of the trade.
Sure. So condoms are a very effective form of contraception. The challenge with condoms is they're often not used correctly. When they're not used correctly, they're not going to work. And so I think that's the challenge. And I think a lot of couples might think, oh yeah, we'll just use condoms. And then when it comes down to it, they just don't. And they can break, the fit can be improper and that kind of thing. So it really is an effective form. I found for a lot of couples, it's not a very desirable form. And there's often misuse.
Okay. So are there different types of condoms for sexual pleasure? Is it a myth? Is it a reality?
There's several different brands, several different types. You'll see a lot of advertising about various, sort of promises. I think some patients do have some preferences, but in the end of the day, it's a barrier method. It may sort of reduce sensitivity for both partners and reduce pleasure for both partners. And I think that's another big driver of improper use. And we just have to be realistic.
Before we get off the topic of hormonal or oral contraceptives, just say if a patient's had a baby or a miscarriage, what's the soonest after delivery or a miscarriage, if there's no breastfeeding going on, that a woman theoretically can become pregnant? I'll leave this question to either Joy or Miriam.
So after without breastfeeding, miscarriage or delivery, usually the return to ovulation has been shown to be as early as 25 to 30 days. So it can extend later, but around that point is when I would often have conversation with women about, let's think about something for birth control if pregnancy wasn't intended and is not intended in the near future.
And for Dr. Kramer, if a woman wants to breastfeed, and we are encouraging women to breastfeed, 6 to 12 months these days, is it safe? Can women take hormonal contraception orally, or what do you recommend?
Yeah, so after delivery, once the breastfeeding is established and you want to wait for the estrogen type, you can take the progesterone type birth control pills right away, the day after delivery. With the estrogen, we want to have breastfeeding established and want to have the clot risk reduced. But with women without risk factors, that can be as early as 4 weeks. They can start almost any kind of other kinds of contraception.
Well, that's perfect. This actually, I think, segues a little bit into a discussion when you just brought up about birth control. What I'd like our patients to really know is when we think of birth control pills, as both doctors have mentioned, the typical use is using a pill that has both estrogen and progesterone. And there are women that cannot take estrogen. And I'm going to ask Dr. Kramer that question, like who should use what we call the mini pill or progesterone only? So when women come to us and say that they're on the birth control pills, again, it's estrogen or progesterone, or it's progesterone only. So let's segue a little bit on Dr. Kramer into types of risk that patients may have that you'd say, I don't want you to be on an estrogen only or estrogen dominant pill. Tell us, let's move into that direction a little bit.
Sure. So patients that I would be afraid to give estrogen to is anybody who's had a personal history of a clot, somebody who has hypertension, somebody with diabetes who has vascular complications, somebody who has migraines with aura, somebody who has breast cancer or severe liver disease. But luckily, those are not generally risk factors for the progesterone only methods, which are great. And I would say it's important to talk to your doctor because not all birth controls are created equal. So if you don't like a side effect from one, we have birth control pills that have less kind of the male hormone side effects now. It depends what is important to you in the in your birth control with what kind of pill we'd steer you to. Although there are certain patients that I think estrogen just wouldn't be safe for.
And you would have a consultation with those patients in particular. So if they've had what we call DVT or blood clot in the legs or lungs, you would talk with them about that. And they can still find a method. Okay, we're going to.
Absolutely. I think, somewhere there's a method for everybody. We have so many great methods now. I think that would be my biggest take home method is, come in and talk to us because there are lots of wonderful methods, some of them without hormones, some of them with hormones, and tell us about your experiences and we can find something that works for you.
So often I have women coming in with what I call old wives' tales or myths about using contraception. For all of you on the panel here today, I'd just like to hear from each of you. What are some of the myths that you've heard that we need to debunk? I'll start with Dr. Vidge.
Sure. So we hear a lot of these surrounding vasectomy. I think the most common, there was briefly some literature that described an increased risk of prostate cancer in men who had undergone a vasectomy. That's really been debunked. There is no increased risk. I think men also are concerned about impacts on their sexual function. Will their ejaculation change? Will their orgasm change? Will their erections change? A lot of men will ask about any effect on the urinary system, even though sort of anatomically they're not related, but sort of in the same region of the body. So I think those are probably the most common myths. And the other thing a lot of men don't realize, and we may get into this later, is vasectomy is not effective right away. So that's a really important point that we emphasize to them over and over again. And nonetheless, many of the vasectomy failures are men who do not continue to use birth control and they have an unintended pregnancy before they've achieved sterility. So they're not true failures.
And one of the myths for me is that I've had women that come in pregnancy unintended. They may have been on birth control pills for years and they think that they can stop it. The quote that's often given is, I've been on this 5 years, 10 years, 20 years. I just know the medicine's in my body and it's stored up inside of there. So that's a myth that I always want to debunk on programs like this. Tell me a couple more, Dr. Kramer, that you've heard, and then I'll ask you, Dr. Tidmore, and then we'll move to the next part of the discussion.
It's a great question. So if you're on a birth control and you're not getting your period, it doesn't mean that something's building up. You don't have a lining that's building up, that it's just a thinner lining so that you're not bleeding. The biggest myth is with IUDs that everybody knows somebody who got pregnant and the baby was born with the IUD stuck in its head.
Okay, all right. There is a picture floating around somewhere on the internet with that, but yeah, very unlikely. And in fact, now, as you know, I love hysteroscopy. A great article just this week talks about removal of, safely removing an IUD in early pregnancy, but that's for another discussion. Dr. Tidmore, other myths that you've heard?
Well, most you've covered, but, again, some of the things surrounding some of the side effects of birth control, hormonal contraception is weight gain. A woman will come in with a significant amount of weight gain over the past whatever amount of time that they attribute to the birth control pill or contraceptives or combination. And those things just aren't true or accurate. And it takes time to help women understand the complexities of that and that they should continue to take the birth control, or maybe we can talk about something else that may not give them that quote unquote weight gain.
Okay, excellent. Any other thoughts before we move on? All right.
The birth control causes cancer because it generally,
yes.
Okay.
It doesn't cause cancer. So that would be.
Okay. And even things like rheumatoid arthritis have been shown to be better. You talked about skin. I think we talked a little bit about hair. prevention of some of the symptoms of endometriosis and pelvic pain. So,
infertility, that it won't decrease your future fertility.
That's right.
I think that's also
and as I
important.
leave this part, so if someone is in their early 30s or 20s, has been on the pill for 5 or 10 years and stops the pill today, and they don't have any other risk factors for infertility, how soon can they get pregnant after stopping the pill in general? What do you tell your patients?
2 weeks.
Okay. All right.
Yeah, I generally tell patients when you're ready to become pregnant, then stop the pill because you can be pregnant, right away.
Right. And in young women under the age of 35, we tell them it's 85% chance within a year that you'll be pregnant. So stay on it until you're ready. So I'll go from there. We're going to move a little bit now to, say a woman has a contraindications, not good at taking pills, doesn't want a skin patch. Let's look a little bit about implants, or let's first actually say the IUD. Dr. Kramer, what type of IUDs are currently on the market?
So we have hormonal IUDs and non-hormonal IUDs. The hormonal IUDs contain progesterone, so they cause lighter, shorter periods. And then for women, now the Mirena IUD is actually good for 8 years, which is a nice long time. And then people who they generally will stop getting their period, especially after long-term use. With the copper IUD, it's non-hormonal, which is a great method for people who don't want hormones. They do tend to still get bleeding. And that one's good for at least 10 years.
So Dr. Tidmore, how, a patient comes in and just says, I've heard about IUDs, intrauterine devices. How do you counsel them to choose between a hormonal one and a non-hormonal one? Do you have any words of wisdom for those patients?
Well, first, I take into account what their concerns are. If it's obviously contraception, are they having heavy periods? Are they concerned about hormonal changes, the way they affect other parts of their aspect of their bodies and life? Those are the things that I would consider. I also do emphasize that usually using a progesterone only method of an intrauterine device does tend to make your periods lighter. And that's often a benefit for women. And I also counsel women who insist on something non-hormonal that will not necessarily change your periods, but oftentimes make them heavier. So oftentimes when they go into that conversation and know exactly what they want from their contraception method and understand the difference between the two, it usually goes better as far as helping them decide on which method.
Right. So things like anemia, bad menstrual cramps, heavy menstrual flow, I agree with you that I would most often try to recommend, be patient-centric with speaking with the patient about a hormonal method. The other thing I find, it really makes me sad, is when patients come in to have their progesterone IUD removed, because again, 40 to 60% of women don't bleed at all. That's because the lining of the uterus is so thin. So I think it's our role as healthcare providers to make sure that women know that about half the time they may totally stop their period within 6 to 12 months, and it's okay. And that tissue, as Dr. Kramer mentioned, is not building up. How do you explain, Dr. Kramer, how these IUDs work? What's the scientific evidence for what we know? How do they work? How soon do they work?
So the IUDs though the hormonal IUDs cause thickened cervical mucus, so the sperm can't pass by, but it's also the foreign bodies in your uterus make it an inhospitable environment. So even if a sperm did get by, it couldn't implant.
And how about the copper? Would you say both work kind of the same way?
So the copper is more of the foreign body and creating a hostile environment, but also it changes the pH of the cervix. It changes the environment so that it's unlikely that a pregnancy would occur.
Okay. And for both of our gynecologists, adolescents are sexually active, and we want to prevent unplanned pregnancies. Can adolescents use intrauterine devices? How do you counsel adolescents and their parents about use of intrauterine devices?
Yeah, this is a conversation that's becoming more prevalent these days. And oftentimes young women are coming in with their parents or a parent to have these discussions. So I think an IUD has proven to be a great form of contraception for young girls, depending on their circumstance, other medical conditions. I do talk to parents about the method of inserting the IUD as probably the barrier to the next step to making that choice. But oftentimes we work around that, and we'll make the choice, based on what their needs are.
So it is okay for young women to use intrauterine devices. Does it make them sterile when they're later in life?
No, it does not.
Okay, excellent. So many studies, what affects sterility is sexually transmitted diseases, gonorrhea, or chlamydia. It is not the IUD. And also this risk and things that women hear about uterine perforation, migration, having a skilled provider putting the intrauterine device in is an important thing from the beginning. So Dr. Vidge, we've been talking a lot about women and contraception. It takes two to tango. So let's hear from you let's first just talk about how do we get our patients to talk to their partner about contraception?
Yeah, it's a great question. And historically, and still today in this country, sort of the burden of contraception really has fallen on women, and men, are not always doing their part. So I think, every couple has unique circumstances, unique goals. And I think, one of my main messages is for couples to recognize that the male has options too. And if it's a couple that really feels like their childbearing years are over, to at least have vasectomy as part of the conversation. It may not be right for that couple, but to at least have it on their radar. So
we've heard of the word vasectomy. Where is it done? How's it done? How's it scheduled? I'll just kind of leave lots of questions because many people don't know. Let's just say, what is vasectomy? Define it, and then I'll ask you to broaden that discussion with how it's done and where.
Sure. So in men, the sperm are produced in the testicle, and they're then stored in what's called the epididymis, which is a small structure that sits kind of right on top of the testicle. And when a man ejaculates, when the semen comes out, the sperm are released from the epididymis and they travel through a long tube. It's about the size of a spaghetti noodle, goes up into the pelvis and delivers the sperm into the urethra or the P tube. And so our sort of main option for sterilization in men is to cut the vas. So vasectomy is to cut the vas deferens. So we're basically causing an obstruction to sperm flow by design. There's lots of different ways to accomplish that surgically, and there's several different sort of acceptable techniques based on our guidelines.
So how are we doing it at the Cleveland Clinic and in your hands and your department?
Sure. So about 95% of our vasectomies we do in the office. So Wow. It's an office procedure. The patient is awake, just using local anesthetic. There are some situations where we prefer to do these in the operating room, primarily if a patient has very difficult anatomy. It's difficult for us to feel the vas, or if they have a lot of anxiety, pass out with the sight of a needle, that type of patient, we tend to just think, okay, you'll do better asleep. And we tend to use what's called a no scalpel technique. Most of us use that, which essentially means that we're not cutting the skin, we're dividing it. It's been thought that reduces pain at the time of procedure. And then there's a lot of urologists here that do these, and we all tend to occlude or block the vas with different methods, whether it's clips, ties, removing a segment, cauterizing, putting some tissue in between the ends. As I mentioned, there's several acceptable methods, so it's really just based on surgeon comfort and preferences.
So you mentioned earlier that it takes time for a vasectomy procedure to work. Tell me, what does that mean? So if a male has procedure done on a Friday, let me first work through what's his recovery going to be like. What's the partner going to see here or have to do for the individual? When can he go back to work? Tell me a little bit about the immediate post-op course and then when pregnancies can occur.
Sure. So we actually schedule most of these on Fridays by design. And the reason is that most men can recover the weekend and go back to their jobs Monday. People who have very heavy duty type jobs, very heavy lifting, very active jobs might need to be on a lighter duty arrangement for about a week. So a week is really the longest that I restrict men from doing anything vigorous. So for that initial weekend, they're kind of laying low. They'll be icing their scrotum, not doing any heavy lifting or vigorous activity, as I mentioned. We do not give narcotics for vasectomy. They're just not needed. Tylenol and Advil are generally sufficient, and a lot of my patients aren't taking anything. And then, once they get through that initial period, again, they're sort of back to their normal life. The scrotal swelling, the swelling around the testicles does persist for a few weeks. It just takes a long time for that to go away completely. And in that time, they might be wearing sort of some tighter underwear for support. And then when we think about when they're clear, when we cut the vas, there are still sperm sort of downstream from where we cut. So several subsequent ejaculations, there's still going to be sperm. And we've studied this, and every man clears that sperm at a different rate. So one guy might clear it in 2 or 3 ejaculations. One guy, it might be 30. So instead of kind of prescribing the number of ejaculations post-procedure, we tend to just say, anywhere from 6 to 12 weeks, depending, again, surgeon preference, is when we would first check a semen test. And it's at that time that we can determine if that man has cleared. And at that point, we would then reach out to them and say, okay, you are good to stop using other forms of birth control. So I think that's a big fundamental difference between female and male.
Right, so 6 to 12 weeks. But
Sure.
you do, for your post-op instructions would say, come back in 6 to 12 weeks. Do they do the testing at the clinic? Do they bring the sample from home? How do they actually do that part of the procedure?
Yes. Yeah, it's a great question. So we have 4 andrology labs. That andrology is a lab that does semen testing sort of all over Northeast Ohio to make it convenient for patients. They can collect at home. They do still need an appointment to designate time to look at their sample, but they can collect at home. We also do have collection rooms in our labs for patients to collect on site. And there also are private companies that offer home vasectomy semen testing. So the patient can collect at home, ship it back, and get word from the company on what the result looks like. So it's pretty flexible for patients, but despite that, the compliance rate with post-vasectomy semen testing is poor across all regions of the country. It's only about 50%. So we're always thinking of ways that we can try to up that. So again, we don't have unintended pregnancies.
Right. So if you do the job correctly, so to speak, and they come back 6 to 12 weeks, what's the failure rate? What do you quote your male patients and their partners for vasectomy?
So they're over 99% effective. So about 1 to 2 in 1,000 men will fail. So we sort of joke as a specialty that that's partly why the compliance is poor, because we sell this as so effective. They think, oh, I'm good. I'm not going to come back and get my semen test. And honestly, a lot of men probably get away with that because it is a very effective form. But many of the pregnancies, as I mentioned, tend to occur in that initial period when they think they're sterile and they're not, or they're just sort of hedging.
Good. This information is helpful for me because I think now what I will start doing when I see a patient who says, well, I don't want to use the pill, I don't want the IUD anymore, is to encourage her to continue on a method of birth control at least for 12 weeks after the vasectomy, since she says her partner is going to be have sterilization. And again, people change their mind. We'll talk with Dr. Titmore in a second, but for men, how often do men have regret? And if they do, can a vasectomy be reversed?
It can. So if we look at sort of published data, it's in the range of like 3 to 7% of men will seek a vasectomy reversal. So it does happen. We do have options for those that change their mind. That being said, I do counsel men to think about it as permanent because not all vasectomy reversals work. And they tend to be not covered by insurance and have a pretty hefty out-of-pocket price. And so it may not be an option for everybody. So I don't tend to push the guy that says, oh, I don't want kids the next 2 years, but then I'm going to think about it. That's not a good vasectomy candidate. So there are options, but again, we try to emphasize the fact that they don't always work and it's expensive.
Expensive, correct. And my final question or two is, we have many methods for contraception for women. What's coming down the line? What's being researched? Will men take a birth control pill? Is anything being designed for them? Or are they thinking of ways to block the vas deferens, but have that reversible. What's happening in that literature, your research for men? What do we know?
That's a great question. So there are a lot of things in the pipeline. The goal is to find something reversible. So for women, there's a lot of reversible options, and there is not for men. There are male birth control pills that are being tested. What they essentially are is they have various versions of testosterone in them, because testosterone, a lot of men don't realize, actually can make you sterile. There's nothing that is FDA approved and sort of ready for, for patient facing care yet. But it wouldn't surprise me if there is in the next 5 to 10 years. And then there are a couple experimental options, again, that are out there that are, the goal would be to occlude the vas or block the vas in a temporary fashion that could then be undone. So injecting an agent into the lumen or the hole of the vas that you can then dissolve later. Mm-hmm. And there's actually even talk about developing a vaccine-like substance that targets proteins in sperm. So none of this is ready for prime time, but hopefully it will be. So again, the more options that people have, the better. Excellent.
So I've got a couple questions for Dr. Tidmore.
On my schedule in 2 weeks. So we have to figure out how to, accommodate that young woman. So yes, to answer your question, short answer, yes, the diaphragm and cervical caps are still viable methods of contraception, barrier methods that women are using, along with spermicides that are now available, over the counter, obviously. Yes, they are.
Excellent. And we were going to speak about the injectables, the Depo-Proveras, the implants. In just a few brief moments, if you could tell us what are the implants, how do they work, and how long do they last?
So the two implants are Depo-Provera and the Nexplanon, very reliable and effective birth control, primarily because of limited user error. And oftentimes, when busy lives, these are just what the doctor ordered. Mm-hmm. So the Depo-Provera, you come in every 3 months to get this injection, and the Nexplanon is inserted in the arm, and it can last up to 3 years. So they're progesterone only. Again, they work to prevent pregnancy with progesterone, and usually are very well tolerated.
Right, and these can be given in a doctor's office. Our nurse practitioners are learning how to place the Nexplanon and also to give the injectables. Anything else, Dr. Tidmore, that we should know about contraception? We've gone through a lot for women and for men. Is there anything I forgot or that we failed to mention?
Well, just a note on, we've covered just about everything, but surgical management and tubal sterilizations are still a viable option for women who are, either done with their childbearing or have decided that's not a part of their lives. We can do them as intervals postpartum, laparoscopically, or immediately postpartum after delivery, along with immediately after cesarean sections too. So they're still on the table, viable options for contraception.
Right. And as we spoke about for a vasectomy, it is permanent. We as gynecologists, if women are under 30, less than 2 children, when I say hesitant, it doesn't mean we would not do a tubal, but there's a higher regret, the fewer kids, the younger age at delivery. So that is very true. And that would be something that I'd like to just our patients to know if they're pregnant and they really know that that's going to be their last baby, to speak with your provider in early pregnancy, because sometimes if you have an epidural or a spinal in and you did not want more children, the tubal ligation can be done at that time. Is that still correct, Dr. Tidmore?
Yes.
Possibly, if the hospital's not really busy and things like
right.
that.
Depending, but
right.
Yes.
And the other thing that we wanted to just mention is the IUD can be placed, believe it or not, at the time of a C-section or delivery. And it often stays in, and it can be immediately postpartum for placement. So, as we're closing here, we've learned a lot of information. I'm going to ask you for 30 seconds or so, a little bit more if you need it. What's the take-home message that you want women and men to know today about contraception?
I just would really love to decrease the number of unplanned pregnancies. Just have people be more empowered to take control of when they want to have children and how many. It's really important, and that we have so many more options now in birth control, and that there are things that you can use. And please come in and have conversations with us.
Thank you. Such wise words, and we'll certainly call on you.
I think my main message is that vasectomy, which again is really our only option for men, is underutilized. And I think the burden of contraception has been carried by women for far too long. And there are many couples or single men out there who vasectomy is right for. And we have options, virtual consultations, sort of at the ready every day of the week at every site, to at least discuss the procedure and educate patients on whether it's the right option for them. So just knowing that it's out there and that it's, a relatively quick, minimally invasive option, that may be right for many men.
Great, such sage advice. I really appreciate that. And Dr. Tidmore, what's the take-home message? Something that you want our patients to really hear and embrace?
Again, to echo Dr. Vij, the burden of contraception has been on the woman, and I don't foresee that changing in the near future completely. So I think my message would be preventing unwanted pregnancy has to be the number one thought process when a woman comes in looking for contraception. And right now we have so many options available. And there's, and we have people to help in specialty situations as well. So talk to your doctors or your healthcare providers and make sure they understand what your desires are and go through the options with you and be educated, because preventing a pregnancy is optimal, particularly in this day and age.
And I'll put a plug in, and it'll be on our website. And the Cleveland Clinic, we now, as you know, on some Saturdays are holding for women a contraceptive clinic. So we will leave this information on our website, how to access our contraceptive clinics that are currently running on Saturdays, but you can also speak to any healthcare provider in the Women's Health Institute. And joining us now for a discussion about emergency contraception and more is Dr. Ashley Brandt. Welcome, Dr. Brandt.
Hi, thank you for having me.
I am so glad you're joining us. And so, I do have patients that reliably use their condoms and most of the part reliably use their birth control pills. But what can I offer a woman if there is a contraceptive failure, or she forgot to use birth control pills, or the condom was displaced? What are options for women in terms of this emergency contraception I've heard about and our patients have heard about? Tell me more.
Emergency contraception refers to any birth control that can be used after sex has occurred. So there are two broad types of emergency contraception. Those include pills or intrauterine devices or IUDs.
If you had intercourse today, did not use the method, the condom came off, you forgot your pills by a couple of days, I understand that there's two types of emergency contraception. One is it still called Plan B, and the other is ulipristal or Ella?
Yeah, so for the pill types of emergency contraception, you're right, there are two different types. So Plan B and Ella are the brand names of those two different types. There's a number of other brand names available that are very similar to Plan B, and that's available over the counter. And it's a single pill that needs to be taken ideally within 3 days of sex, but maybe up to 5 days. Ella, which is also called ulipristal acetate, is only available by prescription. So that's something that you would need to reach out to your doctor or healthcare provider about, and they could write you a prescription for that. And that one is very effective up through 5 days after sex.
Now, how would a patient decide whether it would be Plan B that she can buy at the drugstore or get a prescription? I've understood maybe that the weight of the patient's BMI, does it make a difference for effectiveness for either plan? Or what should our patients know?
So Plan B, or the ones that are available over the counter without a prescription at the pharmacy, do start to become less effective or ineffective as someone's weight increases. So especially for people who weigh about 195 pounds or more, those over-the-counter options are less effective. Those patients really should reach out to their healthcare provider and try to get a prescription. Now, if it's not feasible for them to get a prescription, say they don't have a healthcare provider, it's still worthwhile to try the over-the-counter option, but the prescription option is more effective.
And does insurance usually cover these? I know that's a big question. Or is it a copay or out of pocket?
So that will definitely depend on the patient's insurance that they have. Oftentimes they are covered though. So for example, Ella is the only prescription emergency contraception. So for patients that have good insurance coverage, it should be covered without significant copay or cost sharing.
Okay, excellent. And again, to remind me, for Plan B, how many pills do the patients take?
There are a couple of different options available, but the one step or the one pill is the most common one that patients should be able to find.
Okay. And the Ella is how many pills?
That's also just one pill.
Okay, excellent. And so patients, if someone came to you, Dr. Brandt, and just wanted to have a prescription for Ella, she weighed 200 pounds, she wanted a higher effectiveness, would you give it to her as a means of protection in the case there was a contraceptive failure in the future?
That's a great question. And the answer is absolutely yes. So having a prescription in advance of needing it makes it easier to use it when you do need it. So for anyone that's not using a regular method of birth control or another hormonal method, it's totally reasonable to have an advanced prescription on hand, and even to fill that prescription and keep the pills in their bathroom for whenever they need them.
Okay. And side effects that you would want our patients to know about if they had the need to take either one of the medications?
Common side effects of emergency contraception pills might include an upset stomach or headaches. Sometimes people have some nausea. It can also affect when your next period is due. So the recommendation is that if you haven't had a period within 2 to 3 weeks of taking oral emergency contraception, you should probably take a pregnancy test or check in with your healthcare provider.
Excellent. And is there an age limit for women, the youngest to oldest, that could use either one of these methods?
There is no age limit. It should be available, the over-the-counter option should be available at the pharmacy regardless of age. And it actually should be available regardless of gender as well at the pharmacy.
That's good to know. So a male partner could purchase this for a patient or their partner. Okay. Now I've asked you a lot of questions about emergency contraception. Is there anything I forgot to ask you that you really want them to know about emergency contraception? Because it's relatively new. I'll just give you a moment to see if there's anything that you might want to share that I didn't ask you.
So the intrauterine devices are actually the most effective form of emergency contraception. And so if you're in need of emergency contraception, it's reasonable to reach out to your healthcare provider to talk about whether an intrauterine device might be the right method for you. Obviously, they provide ongoing protection against pregnancy. And so people that get IUDs for emergency contraception end up having lower unintended pregnancy rates moving forward because they've got highly effective birth control on board.
So a patient, if she calls you tomorrow, she had sex last night unprotected, could she come in and see you for an IUD insertion? We talked a little bit earlier with as you heard, with Dr. Kramer and Dr. Tidmore about the use of this. So how soon after unintended intercourse or not having a method of contraception could it be placed? How many days later?
So ideally, the IUD would be placed within 5 days of unprotected intercourse. But it's always worthwhile to at least schedule an appointment to have a conversation. Even if you decide that an IUD is not the best option for you, at least you've explored all the options with your healthcare provider.
Excellent. And I understand that now the progestin IUD, in addition to the copper, can be offered as another method of emergency contraception?
Yes. So the copper IUD had been known to provide pregnancy prevention even after sex had occurred for a while now. But the newer evidence, newer data suggests that the hormonal IUD also works like emergency contraception.
Okay, that's perfect. Perfect. So I want to pivot a little bit to a couple other methods of contraception, probably less popular, but I still think it's a great information we need to share. You know, patients talk about the rhythm method. I'd like to know what that is, and the natural basal body temperature method. Some people just don't want to use anything. So what is the rhythm method? How effective is it? How do you practice it?
Yeah. So the methods that you're talking about, they all fall under the umbrella of what we call fertility awareness methods. So these methods allow someone to rely on their natural signs that their body gives them about their fertility. So the rhythm method involves paying close attention to your cycles and the rhythm of your cycle to help identify your fertile days and your infertile days, and so that you can either avoid intercourse on the days that you might be fertile or use other forms of protection like condoms or other barriers on the days that you might be fertile.
Excellent. And
you also, oh, go ahead.
No, I was going to say in the basal body temperature, what does a woman actually do if she wants to employ that method? Tell us how that works.
Yeah. So the basal body temperature method involves checking one's basal body temperature first thing in the morning to identify signs of ovulation. So it's a special type of thermometer. It's not your regular thermometer that you're going to have to check a fever at home. It can identify very subtle shifts in the temperature, which signify changes in the hormone levels. The basal body temperature method can be used in combination with other signs, such as checking one's cervical mucus and also paying attention to the days of the calendar to help identify the days that someone is fertile.
You know, I want to ask you, Dr. Brandt, there's something new I've read about that women can buy over the counter, potentially, or either it's a prescription, but a new vaginal gel that has no hormones in it. And I think it's prescription required. Do you know about that?
Yeah, so the brand name of this new vaginal gel is called Efficacy. And you're right, it is available by prescription. And what it does is it changes the pH of the vagina so that it incapacitates the sperm. The sperm can no longer do what the sperm need to do in order to cause pregnancy.
And how effective is that?
So it's similar in effectiveness as things like condoms or other spermicides. So not one of the most highly effective methods, but definitely better than not using any contraception at all.
Great. So our doctors can prescribe that if a patient wishes to try something rather than nothing, and it's called Efficacy. And how is it used?
So it comes in individually packaged applicators. And so before intercourse, the person would insert it into their vagina. And as long as it's there before intercourse occurs, it helps prevent pregnancy.
Anything else that you would want at this point is sort of a take-home message for our patients? I'm going to give you 30 to 60 seconds to kind of tell us what you really want your patients to know or our community to know about contraception.
You know, I see so many patients who tell me that they have tried a few different methods of birth control and they had side effects. And so they decided that birth control wasn't good for them. And I just want people to know that there are so many options out there, new methods coming to the market every year. And so even if before you had decided that there was no method that fit right for you or your life, go ahead and talk to your healthcare provider about it. Find out what's new, what's available. And your healthcare provider should help work with you to figure out what qualities in a birth control method are important to you, what side effects you want to avoid, what other sorts of effects, like helping with your periods or things like that, you want to get out of your birth control use.
Excellent. Well, again, I want to thank you for this sage advice, and your expertise is unlimited. So I thank you for all you're doing for our community. Thank you so much.
Thank you.
So to each of our panelists, first, I just like to say that thank you is not a big enough word. Indeed, this was a robust and factual discussion. Thanks for dispelling myths and old wives' tales about contraception. Your expertise, insights, and explanations about the myriad types of contraception will enable our patients to understand that it's possible to find a safe method of contraception. And thank you to all of our viewers for joining us today for this program. A copy of this session, along with all of our archived events, will be available on our website, clevelandclinic.org/Celebrate Sisterhood. Just a reminder, this event was pre-recorded. If you have any questions about the information shared today, please email us. And remember, we are here to help you. For further information regarding birth control or to schedule a consultation, please call 866-320-4573 or visit clevelandclinic.org/appointments, APPTS. Please stay healthy and stay safe. Thank you.